Parkinsons is really two things. It absolutely is it's a problem with movement itself. A lot of how we move in space is dependent on having an intact habit system. Habits are things that we work on through our life, and we get really good at it that they become second nature. These habits of movement, things like even walking, become impaired. So the question is, what does an impaired habit look like? That is Parkinson's disease, and what that is really is slowness and stiffness. I think in general, most people would recognize Parkinson's as that. The part that people don't realize is that Parkinson's is also a problem with thinking. I need to create the best brain that I possibly can that does what? That allows change to happen, that allows flexibility of the brain to do its job, to say, gosh darn it, I can do this workaround. 50% of any treatment of any brain disorder of any kind is lifestyle. I think on face value, the idea of physical activity and keeping active, hands down, I think no one would disagree with that. The more specific a learning task is, we'll give Sudoku as an example. You're going to get really good at Sudoku, very specific, right? And that's about it, right? So when people talk about cognitive gaming, please, right, ask the question, how specific is that? Now, there's other types of cognitive things that you could do. I think obviously things like instruments and music, but I think you always have to be thinking about how much problem solving is involved. I mean, it's really, ask a teacher is what I would say. They would tell you right away, yeah, that's too easy.
People will be familiar with the term Parkinson's disease. They'll know it's a neurological disease. But can you tell us how it manifests itself in patients, at what stage in life? And historically, what has the prognosis been for patients who have been given this diagnosis?
Absolutely. Well, I think first and foremost, Parkinson's disease is a disease of the E gene. So it's something that we would typically see manifesting in older individuals. And I think it's most recognized by people as someone having a tremor. But the truth is, that's really just a very, I would say, minor part of what Parkinson's is, because fundamentally, Parkinson's is really two things. Number one, it absolutely is a challenge. It's a problem with movement itself. And one of the reasons why that's such a key feature is that a lot of how we move in space is dependent on having an intact habit system. In other words, habits are things that we work on through our life, and we get really good at it that they become second nature. Dopamine is a chemical in the brain that is supporting habits. If dopamine drops for any reason, and in the case of Parkinson's, it's because some of the cells that produce dopamine are either gone or died, or what are remaining are not certainly providing enough replacement, so it's not picking up the slack. So we see a decrement in dopamine. When that happens, these habits of movement that have been, again, you've practiced your whole life, you've gotten really good at second nature, things like even walking, become impaired. So the question is, what does an impaired habit look like? Well, that is Parkinson's disease, and what that is really is slowness and stiffness. That is what that looks like. And in fact, there's nothing else that looks like that. That's why so much of Parkinson's we talk about as a real clinical exam, because we can pick that up. We literally can see that. I think the other thing that's interesting is, while we think of slowness as kind of slow movement through space, and that's true, people can move slowly, right? They look like they're literally more deliberate in their movement. They seem to be taking their time, if you will. But I think the other key thing that you see with this is that it's also an issue of the bigness, or in this case, the lack of bigness. We call this amplitude. Things get tinier, so movements get small. That's sort of the idea of a shuffling gait. If you have a stick man, just an example, would be a normal kind of movement of the legs, and then they start getting small. This is sort of how everything gets kind of crunched down and the amplitude of movement gets diminished. That is also what we see as slowness. Slowness is not just a speed, it's a lack of amplitude. And then with that comes stiffness. So I think in general, most people would recognize Parkinson's as that. The part that people don't realize is that Parkinson's is also a problem with thinking. And in fact, even in normal individuals, people without Parkinson's disease, particularly as we age, we actually become more and more reliant on our thinking to be able to move effectively through space. Now, all of us do this to some degree, and we see examples of this all the time. Again, the idea, remember, habits. So one hand, a lot of our movement is second nature. Think of the basketball player on the court. Second nature, he's running down the court. He's even dribbling perhaps without thinking about it. But what he's also using is a cognitive strategy. So this is a thinking strategy of where I'm going to move, how I'm going to move, where I'm going to make the shot. That's the motor phenomenon as well, right? So here you have movement defined not just by the habit, but the thinking component. Okay, so what happens to thinking in Parkinson's disease? And is that compromised? The answer to that is yes, it is. And in fact, we can see even early upon diagnosis. So this is when early features are beginning to manifest and people may begin either to notice a little tremor, and again, that's not needed. They may even notice some slowness in movement or what they may even describe as heaviness. 40% of those individuals at presentation have some changes with thinking. What I mean by that is if I compare their thinking, let's say I do some sort of formal assessment, pen to paper assessment on thinking, having them solve some question or answer questions or solve some problems, I'll see that they're beyond what we call age matched changes. They're 1 to 2 standard deviations away from the mean of what you should be at that age. So it's not just aging, it's actually changes in how I'm thinking. So this, again, is a part of Parkinson's, 40% upon diagnosis, and over time becomes more impaired to the point where we see Parkinson's explaining, about 80% of people with Parkinson's go on to develop dementia, to the point that the correct way to see Parkinson's disease really is that Parkinson's disease is the second most common form of dementia after Alzheimer's in terms of neurodegenerative disease. So it's actually dementia. And that's the part people don't realize, in part because it's not the typical presentation of it like Alzheimer's, but it eventually becomes that. So I think that honestly is the biggest challenge in Parkinson's disease because the medications that we currently have really are not effective thinking compounds. In fact, the truth is, what people may not realize is we don't have great thinking compounds. They just don't exist, which is somewhat shocking given the incidence of Alzheimer's and Parkinson's and the fact that this is only going to get worse. We don't have drugs. But what we have, of course, is lifestyle. And that's the good news. This is the part that doesn't get emphasized enough. This is where really lifestyle matters. It's going to matter when it comes to thinking and how we can preserve what we call cognitive health, resilience, right? And try to maintain as much as we can cognition over time, because not only is that going to impact how I make decisions, of course, but my argument is it's also going to impact how I move. And in this case, not only, again, I'm already saying there's some motor impairment, but now if I can't strategize, if my thinking is not quite right, I begin to do what? Fall. So falling really is considered a predictor for cognitive issues, right? And then people are surprised, like, okay, well, doesn't dopamine help falling? Well, the answer to that would be, well, not really, because we're back to thinking, right? So dopamine does not help thinking that much. And so this is a cognitive issue that's being added to the motor problem. And then you start having more falls, more dependency for daily activities, daily living, and these sorts of things. Cognitive health, cognitive issues are probably the biggest, foremost problem we face to date in the aging population in the world, really. It's an aging issue. Our population is aging. And we have not much on the pharmacological side, but we have lifestyle. That message is not getting out strong enough. How important that message is and how important is it for people to access, and I mean within communities, the idea of investing in that in the communities has not been emphasized enough.
I want to come to those lifestyle measures in just a second. Could I just broach the subject, though, of the origin of this problem? I spoke with neurologist Dr. Ray Dorsey out of the University of Rochester, New York, a few months ago, and he believes that the cause of Parkinson's today lies in environmental pollutants, chemicals, pesticides, etc., because he said there is no record of Parkinson's at all in the human population prior to the inception of the Industrial Revolution. What's your view on what's causing Parkinson's today?
Yeah, I mean, I think certainly if we look at the data, and I don't think there would be any disagreement there. I mean, the idea that environmental, whatever that is in the environment, right? Obviously, toxins is a thing. When you think about pollutions, definitely is plays a role. And I think we have a lot of great data that supports it, a number of very landmark papers that support that there is some role in the environment that started off even with the idea of looking at rural versus urban areas and differences in risk there. I think that is very strong. I think that was followed up by a perfect case example of that. That was in the 80s with the MPTP story and the story of the frozen attics. I mean, that is a convincing story that there is no doubt that there are a number of toxins that can have direct hits on what we call the energy-producing parts of the cell called the mitochondria. And I think that is pretty clear. I think what's been added to that is the idea of genetics, right? And so this, again, genetic environment interaction. I think toxins provide a perfect model example of how the environment can do it. The idea that other things could be out there, absolutely. I think obviously what comes to mind, though, are what other types of injuries might be present that are not necessarily a toxicant or chemical. I mean, I think head injury, right? That's come out front and center in the news, right? I mean, the idea that I'm literally physically bashing in my head. I mean, that's got to mean something, right? Whether you have a toxin or a full blood injury that is repetitive, I mean, that's going to do something too. And I think that evidence is also pretty clear that that's true. I think the other part of the story, which I think this is where it gets really interesting, of course, is the idea that, we haven't really seen pockets of people with Parkinson's, right? We see areas, general areas. Obviously, people believe that North America has a slightly higher prevalence as a country. And then the explanation there is the industrial age and pollution and all that. Certainly, there was a good case for that. But I think the other point, and this came out a lot with the twin studies, there's now been a number of Swedish twins, the veterans, World War II twins, that is clearly shown. And that predates some of the big genetic studies, but these were the really early studies where they were looking at, genetic risk and just asking questions about twins, right? And that data was pretty convincing again, and it still holds water that, if one twin had Parkinson's disease, the question was if the second twin was identical or not identical, right? What would happen to the second twin? Well, if it's genetic, meaning it's purely just handed down as a genetic cause, in theory, all patients with Parkinson's disease that had an identical twin should have Parkinson's disease, right? That's a no-brainer. That they should have it because they're identical, right? That would be genetic. If that was not the case, if the second twin had the same likelihood of getting Parkinson's as the non-identical twin, then the idea would be that it's not genetic, it's environmental or some combination. So what the Swedish twin study showed, and also the World War II veteran studies showed, is that the identical twin, the brother of the person that had Parkinson's, the identical twin, did not have any higher likelihood of getting PD. They didn't. So it's also pointing out that you can't explain it strictly by genetics. So on one hand, you're saying, well, okay, we're not getting poxes of toxins. So if this was purely toxin, we'd be seeing it all over certain areas of the country where there's high pesticide use. And there is some differences there, but certainly not pockets, right? We don't see an MPTP outbreak. And again, in the MPTP outbreak, they were just literally injecting it into their veins. I mean, this is pure MPTP almost that they were injecting, but we don't see that, right? So the idea, and on the other hand, it's not purely genetic because we're not seeing identical twins necessarily over age 65 anyway, that are clearly getting it every time their brother gets it. It does kind of support the idea of this mixed relationship with genetic environment. And that poses a really interesting question about, okay, so what would you be looking for in genetics, right? Well, that's quite broad. And these are things that we've called risk factors, rather. And this could be anything from how I metabolize toxins. I mean, maybe I'm a poor metabolizer of toxins. And in fact, some of the original genetic work were people in the toxin fields, toxicologists, that were looking at, okay, what would I need to be able to rid of this toxin? What do I need in my liver, for example, that we need to get rid of this toxin effectively? Those were some of the first genetic studies. After that, with the introduction of this autosomal dominant, this family with multiple generations with Parkinson's disease, they started looking at other genes that could be brain specific. And that was everything from, genes involved in brain repair, genes involved in, turnover of, protein accumulation. I mean, the list goes on in terms of what are risk factors, right, that have in place some role in the health of cells that if they're not optimized, perhaps are now more vulnerable, right, to a mitochondrial hit. So kind of the dual hit story. I get enough exposure and I'm compromised, right? That causes this sort of perfect storm. So it's not just one, it's the idea that I'm kind of more at risk because I'm getting it and I'm not able to recover fast enough. Oh, and then, right, the elephant in the room, aging itself, right? A lot to do with aging. The aging field is so critical for us because it's really kind of the basis of understanding what the brain is capable of doing and how it changes with our aging with regards to maintenance of the brain, repair of the brain. We know a lot about how much that changes with age, right? So that's, again, the thread underneath it that you can't forget, right? And that's why, again, you kind of pay attention to all these things because any one of these factors are reasonable targets to go after.
Well, let's talk about a target that you've alluded to already. We've already said that we can't rely on drugs in terms of improving cognition. So you mentioned lifestyle and behavioral changes. Could the solution to slowing Parkinson's disease be as simple as going for a simple walk?
That's a great question. And I think that there's a kind of a, I think on face value, the idea of physical activity and keeping active, hands down, I think no one would disagree with that. I think there's some more details that we can talk about in terms of the specifics of that. And I'm talking about it from a biological sense in terms of how we understand, where the brain really engages with the environment and what does movement in space do to the brain. I mean, we talked about habit formation is, obviously habits will form because the brain is engaged and it's going to create a kind of code for that experience, right? So I think the idea here, and we use the term plasticity. That term has now been, beaten like a dead horse. We get it, right? I think there's a lot of interesting ideas behind that. I think, so long story short, yeah, I think lifestyle definitely has a role to play. I would argue as sort of the counterbalance, right? And the idea that, particularly since most people agree that these exposures that we have are lifetime. So it's not, okay, maybe someone lives, by a pesticide factory and they have a massive whatever leak or whatever. But for most of us, this is going to be a chronic effect. So the idea that we are always engaged in some sort of, I would say, not to be paranoid or anything, but, kind of injurious environment that wants to get us, right? And so the best, we can do for ourselves, I mean, I guess we could create a bubble, but that move to Mars, whatever, right? But that's not, that's not going to happen, right? So we need to create a strategy. And that strategy is kind of the lifestyle strategy. It's the counterbalance to this, right? The idea that I recognize that I'm going to go through this. I need to create the best brain that I possibly can that does what? That allows change to happen, that allows flexibility of the brain to do its job, to say, gosh darn it, I can do this workaround because I do that all the time. This is the nature of my brain, is constantly doing workarounds for a specific goal, right? Particularly when there's a specific goal, because what does that do? It challenges a system that has encoded something, that has learned something, and now says, that's not enough. I need to do something more, right? And really that's the premise of what kind of lifestyle is about. It's not just about engaging in or experiencing something, right, and doing it over and over again. It's kind of the idea of what do I need to do to kick it up in gear for my brain to say, yeah, let's keep moving, right? Make it efficient, make it stronger, do workarounds, and I think some of the idea is that on one hand, there's this idea that things regarding behavior like motor movement are systems-based, right? It's not one cell that's taking care of all this. It's really a systems that's going on. And I gave an example of the habit and the cognitive strategy. I mean, that's part of a system. It's just 2 points that I've talked about. There's other parts that involved in motor systems. So behavior is a systems issue, right? Now, think about that for a second. That means there's a lot of different targets here. And that also means there's possibility for what? Compensation, you see? So the brain not only has this kind of cool ability to change at a at a connection level to say, I need to change because things are changing up and I need to make it more efficient, or I need to gain some more skills here. It can also do it at a network level, which is kind of crazy because now you have kind of two dimensions of change that can happen, right? The reason that's cool is because the idea is that in the context of injury, where you have a disorder, let's say, you may have a workaround that's been happening, right? You may have the ability either for the compensation, right, of other systems that are relatively intact that may be able to bring it up a notch, or within a cellular system. You follow me? So in other words, I can compensate, my brain can compensate, and I can also change at a cellular level. And again, so how would I do that? By the experience, by my experience of the environment. And so what am I saying? Challenge, right? Challenge, effort, challenge. We hear that all the time, right? Those are the things that drive what we would say the biggest change in how the brain is going to, create better connections and maybe even compensatory strategies. Does that make sense? So if I think about that in the context of lifestyle, then the question is it enough for me to just keep doing the same old, same old? Well, let's give the example of, I don't know, learning a language, learning a math equation. I mean, how good are you going to get if all you're doing, is reading the same book of, whatever, Spot the dog, right? You're not going to get very good. Your vocabulary is going to suck, right? I mean, you're just not going to get there, right? So that is no different when it comes to physical movement through space. I need to mix it up. I need to make it more challenging. I think the environmental enrichment field, which is where a lot of this work came out of initially, right? The environmental enrichment field is really, looking at what does environmental enrichment do to brains. This was a lot of really cool animal data that was being done in the 50s and 60s. Ask that question. If I have this enriched environment, what happens in my brain? Oh, right, my brain gets bigger, right? That's what it showed. And is it more cells or is it more connections? More connections. How do you like that? More connections and more blood flow. That's cool, right? So you don't necessarily need more cells. You need more efficient cells and you need more connections. And that happens when we make things harder. So when I think about that from an exercise point of view, the truth is, the rehab field, I learn a lot from talking to people in other fields that are much better at this than me. And that a perfect example of that is the physical therapy rehabilitation field, which that science of physical therapy rehab, what we call motor control, kinesiology, has really taken off in terms of really understanding this, looking at it in the context of spinal cord injury, stroke, and Parkinson's, and all these other. They began to really study this in terms of how do I make things more challenging, right? And, people talk about things like, well, on one hand, you can make it harder by making it more, faster, for example, or one could, make things more skillful, right? So I'm not just moving my legs, I'm actually playing a game, right? I may be playing tennis where I'm having to change not only my speed, but I'm changing my direction, or maybe I'm turning, right? And then I can make it harder by, making it in a very enriched environment. What's cool about that is that a lot of studies in the field of physical therapy, biokinesiology have shown that learning is best. You learn better, you retain better when things are variable, right? So instead of block practice where, let's say I'm throwing the ball, someone maybe 15 feet away and I have them stay there for 100 times and then have them go out another 15 feet and practice that for a while and have them return the next day to see how well they catch the ball. And I compare that to a person who is moving variable distances from me, right? And catching a ball. What you find is the person who went through variable practice does better, does actually better in being able to catch the ball, retaining that skill than someone who had blocked. What is that telling us is that complexity is how we learn. Because what do we do when we make things challenging? Think about this for a second. What's the essence of all this then? Problem solving. Problem solving. I am working through the problem, you see. And it's the mind, right? It's the brain working at it, right? I'm going to figure this out, right? That's learning, you see. And what's so cool about that is we know this. Oh my God, we know this. This is, talk to any teacher who gives tests and exams and why are they doing that? Oh, because it works. because I'm taking the information I was given and I'm reworking it in a way that I understand it, right? And I'm figuring it out. Movement is no different than that, right? And people are always shocked, like, oh, I don't get it. Really? I mean, it's the same brain, okay? This is not another brain. This is the same brain. We're working many of the same circuits. It's the same idea. Does that make sense? So the idea of problem solving, when I'm making things harder, and that means mixing it up either to a different type of environment, right? So putting that in an environmental practice. I think of trail running as an example, right? That's very different than running on a treadmill, for example. But you can make it, running about a treadmill, if I do what? Increase speed, maybe. Does that make sense? I know a lot of work is being done in perturbations, making things like unexpected and how I'm experiencing that, responding to that. Does that make sense? So I think the idea really, even when it comes to exercise, it's really about variability. It's really about challenging, making things harder as much as you can. That can also include the environment. Changing up the environment is all good.
So if I understand correctly, the brain thrives more so from novelty than it does repetition.
And challenge. And again, challenge, you could say, is some aspect of novelty, just mixing it up a little bit. That's right. And my question, so this is the other really kind of what I feel like elephant in the room, like a kind of a duh moment, right? Which I love. Okay, so what do you really think exercises do? I mean, I have trouble with this in the exercise field. It's like, the idea that somehow exercise is like pixie dust, all right? Like, stop. This is painful to hear. Okay, it's not pixie dust, right? It's really about the brain engagement. You follow me? I mean, the brain is the leader of this. Brain is not passive by any means. And simply throwing pixie dust at something, if it doesn't need it, it's going to go, please don't do this to me. I don't need it. So what am I trying to say? It starts with the brain. It starts with neuronal activity. It starts with what is the problem? What's the challenge? Where does the brain need to go, right? What's the goal? Brain activity is key to change. It's not going to happen for something being thrown at the brain. It's happening because the brain sees the need to change. And one of the easiest and fundamental ideas of that is, I have a goal. I have something I am trying to do, right? Okay. So that causes a challenge. And now the brain is going nuts with activity in a very circuit-specific way, whatever that challenge is, right? It's trying to figure out. Now we're matching that need with a resource, right? Now, this is where I think the body-brain stuff gets very interesting, right? Because the brain can do a lot of cool things, and there's lots of evidence for this, where neuronal activity, and by the way, this is being also in many ways studied with cancer, right? Which is cancer cells kind of direct a lot of energy their way. That's how that happens, right? So they're directing this, right? So that's kind of cool because it's kind of a model to look at how the brain functions, which is sort of the same idea. Neural activity creates a need for the neuron, right? And the connections to say, I need more blood flow. I need more energetics to support this goal that I'm trying to achieve. So there are a number of genes that turn on when the neuron gets activated. And some of those genes, which are called immediate early genes, like ARC, one is hypoxia-inducible factor. It's actually studied in cancer. There are CREB, the FOS, all those immediate early genes that are turned on by the neuron. And guess what they do? Well, they direct blood flow. They totally can cause angiogenesis. Release of NOS can cause vasodilatation or dilatation of the vessels going to the brain. So they're already providing like, I need help signal, right? It's being matched, though, right, by what's happening in the periphery. Now, there's a number of things that we look at in the periphery, and I think certainly the aging field has been very interested in the periphery from a vascular point of view, certainly in cardiovascular health and cardiovascular fitness and these sorts of things, which I could say is a proxy, for a lot of other things that are happening, whether they're immune system, trophic factors, and of course, one of the other big ones metabolically, which we totally love, is lactate. So let's go through a story of lactate. Well, first of all, lactate is a healthy and normal byproduct of what happens when your muscles are using up energy, glucose in particular. And it is happening when you're active, particularly when you're exercising hard, and that lactate crosses easily into the brain. What people don't realize is that actually there's natural, normal basal levels of lactate that are present in the brain all the time. Lactate is probably the biggest source, by the way, of fuel to neurons, not glucose, but lactate. Isn't that interesting? What's cool about lactate is lactate does a lot to support synaptic activity. These same connections we're talking about that are working on to being formed to create a goal, right? To support a goal, a new mission. And so here you have, with exercise, this huge bulk of lactate coming into the brain, right, to support that. So that's an example of how these kind of duality, what we call coupling, exercise is a coupling between the brain, the goal, the need to change, right, and supported by many things that are coming in from the periphery, including lactate as an example. Does that make sense? So it's really this kind of cool coupling that happens. It's not just, oh, I'm getting trophic factor in my brain and I'm just going to get better somehow. The key is the goal. And I think when you think about therapeutics, and I'm sorry to go off topic a little bit here, but when you think about how therapeutics are studied, where they're actually literally proposing this to us, right? Isn't the pharma proposing to us like, all we have to do is get dopamine in the brain. All we have to do is get a trophic factor. And you're thinking, how is this supposed to happen exactly? So the brain, because you have trophic factor dopamine, suddenly it knows what to do with that. You know what I mean? Oh, I get it. You want me to what? Walk now? You follow me? It's nonsense. It's never going to happen that way because the brain doesn't work that way. It needs the challenge. It needs to know what you want to do to make that, whatever that source is. And I would say lactate is a huge one for us because it also provides trophic factor expression. Lactate has a duality, not only energetic support, but also releases trophic factor from the astrocytes. But it's doing that in response to what the neuron needs. If you block that shuttle of lactate to neuron, you literally lose connections. That's how important lactate is. That's been shown in the hippocampus. We did some work with that in the basal ganglia. You literally lose connections if you block that. So that's how vital lactate is. But the idea that who's really calling this is really about neurons and circuits and what are you asking the brain to do now? Does that make sense?
Oh, completely. So so as I can give my reading of what you've said there, because you've given a lot of information, essentially any exercise that might be recommended to Parkinson's patients isn't being performed for the benefit purely of the physical benefit of doing the exercise, but for the mental and cognitive stimulation that will come about as a result.
Exactly. And it's called problem solving. But not only that, you're going to love this. Think about this for a second. And this is what makes Parkinson's different than Alzheimer's in the aging field in many ways. One of it is Parkinson's, the whole idea for exercise and a lot of the work that we did and others came out of what? Rehab, you see. Rehab. Why? Why, would you ask? Oh, I don't know, because they're not moving normally, you see. They don't move normally. Not even in the context of dopamine. They do not move normally. So what do we do then in rehab? We correct it. We give feedback. We give strategies to do what? Correct movement, to make people look normal. And that's not going to happen with dopamine. I assure you, that will not happen with simply dopamine. That happens with practice. And that's the duh moment, right? That's when you should say, well, no kidding. Of course, I need to know how to problem solve this to correct my movement, to make it look normal. And that's when we really began to say, wow, okay, this is cool. People with Parkinson's can learn. Of course they can. They may learn differently, but they can learn. And so the rehab, we start with rehab to get them to move normally, right? They take that strategies that they've been learning and now apply it, right, to exercise. Now they can go out and do what? Practice, right? But we would never do that and say, well, good luck. It's like having, a tennis lesson. You're thinking, okay, I'm really good. I got it all figured out. I'm going to just go out there and play the circuit. And then you really begin to go, wow, I'm not so good. I need more feedback before I can do that, right? So that's always the case with Parkinson's disease. Fast forward the aging field and, the Alzheimer's field. Their problem is slightly different, right? So they're not thinking, oh, we need to recover function. Parkinson's, we totally need to do that. And that fits beautifully the problem solving, doesn't it? This whole story starts making sense. I get it. The problem solving with feedback. How does learning happen? By instruction, by feedback. That's no surprise here, right? I recover function and then I do what? I keep it up, right? How do I keep up my Spanish? I practice. I'm always shocked when people go, really? You have to keep doing this? I don't know. What do you think, right? Of course, right? It's the brain, right? It's the brain, guys, right? It's not another system. It's the brain, right? Common sense. So in the aging field and the cardiovascular field, I think there was a little bit of confusion that started happening because the idea was, oh, I just need to what? Get my heart rate up and I just need what? Cardiovascular health. Why? Well, let's think about this for a second. First of all, cardiovascular disease can affect the brain. We get it. And when you look at the field of aging and Alzheimer's, what are the questions they're asking? How good is my cardiovascular health? It's better. My blood flow is better. I don't have cholesterol. You follow me? They're kind of at it from a metabolic side, and I'm not taking away from that. I think that's great. Anytime I can have good blood flow and less cholesterol and less gunk in my arteries, that's a good thing. And that tends to be the focus of aging and Alzheimer's is cardiovascular health. But when I'm talking about how I can really benefit my brain in thinking, and yes, can cardiovascular health help that? Yeah, if I have better blood flow, of course, right? That's what I call low-hanging fruit. But if all logic still holds, then the idea would be, even in the aging field, even in the Alzheimer's field, yeah, I could do something for our cardiovascular health, and that's good, but I can do more than that. And I can use the same rules of the game that I use with Parkinson's, starting at another level. Okay, so I know how to walk. I don't need any type of feedback on that, but I can make that harder for you. I can totally ramp that up harder. I can make it more intense. And intensity has a very confusing term because now you can see how intensity can mean a lot of things, and you need to be really listening to that. Because yes, I could get my heart rate up, and that's back to cardiovascular health again, right? And I would agree, proxies. I mean, maybe my immune system is better. You follow me? There are proxies from that. It's not just about cardiovascular health. It's about more trophic factor maybe to the brain, all these things. But the point is that for my brain to get the benefits of it, not just about blood flow now, right? Again, we agree that blood flow is good. If I can improve that and control immune, that's all good. I'm not denying that. But if I want to really gain the most out of this, what I'm going to do is I'm going to make it more skillful, harder, right? These sorts of things. And the crazy thing here, think about this too, is it doesn't necessarily mean that I have to do mental math. You know, I see sometimes people going, oh, I get it. Now I have to be in a virtual world where I'm like solving like, math equations and going, okay, think about these guys. Back up a second. You're hurting me, okay? First of all, movement in space is complex. It's very complex, right? There's a lot of strategizing going on. So this is the frontal lobe. The basal ganglia is creating skill sets, new skill sets with practice, right? I even have a part of my brain called the cerebellum, which is very much activated with perturbations. It also has a cognitive component. My point is the brain loves movement. Are you kidding me? It loves it. So much so that its effects tend to have what? Transferable benefits. And what do I mean by that? Generalizability. The more specific a learning task is, we'll give Sudoku as an example, you're going to get really good at Sudoku. Very specific, right? And that's about it, right? So when people talk about cognitive gaming, please, right? Ask the question, how specific is that? Now, there's other types of cognitive things that you could do. I think, obviously, things like instruments and music, right? But I think you always have to be thinking about, how, I think how much problem solving is involved. I mean, it's really, ask a teacher is what I would say. They would tell you right away, yeah, that's too easy, right? Yeah, no, make it harder, right? These sorts of things. I think this is the nature of the beast, though, which is how hard am I problem solving here? And if I want to have the biggest impact, that's what we're talking about.
I'm smiling because you're preempting all of my questions. I was just about to ask you about those brain training exercises you can do online and Sudoku, but you've answered that question. Could I ask you just in relation to the progression of Parkinson's disease through exercise, as you've said, and you've underlined the importance of that, how quickly can a patient with Parkinson's see a benefit cognitively as a result of engaging in novel exercises?
That's a great question. I think you have to ask first and foremost, how how long does it take to see these cognitive changes? The truth is, they're slow. I mean, these cognitive changes are not going to be happening overnight. So we're talking years with these changes, you know. So, within, 2 to 3 years, we might see some minor changes, but they're not typically very large changes. And again, this is classic PD. This may be different for diffuse Lewy body, and certainly with Alzheimer's. Every form of dementia has its sort of progression, rate of progression. I would say in Parkinson's disease, cognitive change is slow. So you need to carry out these sort of studies, and they're, these are 5 years out. I mean, this is probably what you would need to really see an effective changes. And there's certainly been some data at that level, but most studies have been short. And so that's been a challenge. And part of this is because, we're very much, I don't know in Ireland, but certainly in the United States, we're definitely pharma driven. People just don't believe you, like, you need a drug, don't you, to do that? It's kind of those sorts of answers that you get. So it's not, NIH is barely interested in it. Michael J. Fox doesn't even support these things unless there's a drug attached to it. I mean, these foundations are only interested in drugs. In fact, some foundations actually say, please do not apply for a grant that has anything to do with lifestyle. I promise you, that's how crazy. Right. If we're drug oriented, that's what I'm saying. They're still thinking it's got to be a drug. And of course, from the logic that I'm telling you, the idea is even in the context of a drug, even in the context of gene therapy, it isn't going to happen unless the brain has some role in this. It has to be involved to make sure that everything is in place to create a effective, connection and a circuit that makes sense to create a goal. Does that make sense? You kind of need that. But back to your point, what I would say is there is certainly data. There have been some longer studies that have certainly supported that. Again, I would still say there needs to be more studies because these are really long-term changes. A lot of it has also been driven by the aging field, but the aging field, if you can imagine, Parkinson's is slow, aging is even slower, right? So these have to be longer-term studies. There have been studies, though, for example, in Finland, there was a study called the FIGHT study where they were looking at 67-year-old individuals, men mostly, who they were engaging. And again, in this case, they were using intensity to mean heart rate, getting your heart rate up. So working at a MET of three METs or greater. So this is metabolic expenditure, how hard you're burning up energy because of your workout. And again, these are proxies, right? People are trying to objectify exercise. So you'll hear things like, metabolic expenditure as an energy proxy for how hard you're working, or what do you call vascular fitness, or aerobic fitness, which is about oxygen expenditure. These sorts of questions. But the point is that these studies have shown, even the 60s or 70s individuals, men in particular, that are able to maintain anything moderate, which is again greater than about 3 METs, are showing some not only maintenance of cognition, but actually some improvement with cognition. And these are studies that have been done over 5 to 7 years. So, and this is really when we talk about blue zones, that's often what we're talking about. I think the key, though, again, is, intensity tends to be more about heart. And you can understand now why. I mean, that came out of the heart field, and that's really cardiovascular field and these sorts of things. But the brain, I would say, deserves more than that. And we know that, right? So the argument here is, okay, that's fine. It's a good place to start, but it's really more than that. And I think the idea that, you're challenging yourself in terms of making things harder, more complex, practicing in novel environments. And if you want to say novelty is kind of a good general idea, that's not a bad idea. And I think that is something we really should be shooting for, which is making it harder for people, and the idea that people can absolutely be challenged. I mean, when I started in the field of Parkinson's disease, that was something that no one would ever think about. Can you actually get someone for Parkinson's to do it? And we're going, well, yeah, you can, and you can make it complex. I think the other point is matching the complexity to where they're at. And this is where learning is really at its best. Learning can happen at any level. It's really about matching the ability of the person, right? Starting there and then kind of building to that. I think you mentioned something about exercise and what happens long term. I think one of the things, and I actually had a friend tell me in this specific way, the question he asked was, can you learn yourself out of Parkinson's disease, right? Can you learn yourself out of this? Because really, that's what we're talking about, right? Learning. I'm challenging myself to learn things create new connections, create compensatory strategies, blah, blah, blah. That would be a learning mechanism. Can you learn yourself out of that? And I would say probably not. And why? Well, I think probably we're going to go back to one of the fundamental points that we talked about, what is in common with all these disorders, and that is called aging. So in many ways, aging may be the limitation here. There are a lot of things that change with aging, and one of them is certainly what are called astrocytes, which happen to be the energy source, really that you want to call anything, the gas tank of the brain, that's it. It's called astrocytes. They're the ones that handle lactate. They move lactate through to neurons. They sense neuronal activity, so they're really the man on the scene or the woman on the scene. They can match the need of the neuron because they're there. Astrocytes change with aging, and they become less efficient deliverers of energy. And that is a very interesting question in and of itself. If we are not able to match that need anymore, right, what happens? So you kind of go back full circle to the question of aging itself. And how can we do something about that, right? I mean, we're really becoming, in many ways, aging experts. How can we bolster that, right? Through keeping with lifestyle, diet, and these sorts of things. But there's a lot of things we just don't understand about aging and how exactly, why these changes occur.
Are you hopeful for the future as far as research is concerned? And do you see any situation whereby exercise will become an official prescription in the treatment of Parkinson's?
Good question. Well, I'd like to think that we were part of the group that did put exercise on the map, but I will tell you how exercise has changed already. I mean, again, when I started, there was nothing about exercise at all on any web page. Now, in fact, I was just looking up incidence of Parkinson's, and the third line was exercise, right? I mean, that's insane. So I think that's out there. I think what I find often is the case is the message is not getting out there appropriately. I find that patients know more than their doctors. Shockingly, how little doctors, inform patients about that. I mean, they're happy to talk about drugs, but in terms of lifestyle, they often don't touch about that. I think if we learned anything, about the brain, is that 50%, I would argue, and maybe higher, 50% of any treatment of any brain disorder of any kind is lifestyle. I mean, that's key. We know that. The case is clear. The brain is at its best when it problem solves. That's what it's for, right? If I am not creating goals for this brain, you are wasting your time throwing anything at that brain. I don't care if you threw, whatever, right? The holy elixir. It's not going to do anything if the brain doesn't have a reason to use it. And until not only, I would say the therapeutic, the pharma field, if they don't get that, which they don't seem to get, right? Because they're insistent, like, all we have to do is remove alpha-synuclein. All we have to do. Well, think about that for a second. Okay, think about this. So let's say the injury is alpha-synuclein, this protein aggregate, right, that causes additional mitochondrial burden, right? We say mitochondrial toxins, mitochondrial burden, alpha-synuclein. Maybe it's a chicken egg thing. Mitochondrial injury causes alpha-synuclein buildup, which causes more mitochondrial deficits, right? I'm going to make the argument, and I don't think anyone would disagree with that, is that this brain, through our lifetime, has been doing changes from the get-go. All right? It's not waiting for threshold for anything. It's just changing. It does that very well, right? And when there's injury, it's doing that as well. All right? It's not a stagnant thing. So the idea that you're seeing something building up in the brain, the idea here would be, well, okay, the brain is constantly making changes. It's doing workarounds. It's making compensatory strategies happening. It's making cellular changes happening, energy more efficient. So this is ongoing. By the time I recognize Parkinson's disease, right, clinically, there's a lot that's been happening. Not only has there been injury as we know it, but the truth is there's been a lot of workarounds. I mean that there have been compensatory strategies happening, right? You understand? I see Parkinson's as all that, you see. Parkinson's disease isn't just about the injury, right? It's about what other compensatory strategies are happening. And some people argue, for example, tremor is an example of that possibly. Tremor may be happening because the cerebellum is getting activated. Now you have tremor. Do you understand? So Parkinson's disease isn't just about cell loss and what's happening as a consequence. It's also what has the brain done to do workarounds. Now, if my argument is, okay, now you've done a lot of workarounds and there's a lot of compensatory things that are happening, and now you're whatever long you've had the disease, and I'm only recognizing it now, maybe you've had it 10 years, right? Maybe the brain's been compensating. Oh, right. You need about, 60% dopamine loss before I see anything. That says a lot right there, doesn't it? There's a lot of compensation happening. Okay, now I see you, and I make the argument that there's alpha-synuclein everywhere. I need to get rid of it. I'm thinking, okay, so what's supposed to happen here exactly? I take out alpha-synuclein, and what? You're going to rubber band back to something? You're going to switch all the way back to where you were before that first injury happened. That's just not going to happen, right? I'm not going to rubber band back. My brain is as different as you can possibly imagine to 10 years ago. So how is this fix supposed to work exactly? You're not going back. Nobody's going back. You're going forward. And until we get that point, like, okay, I may be unburdening maybe this, but I'm not going back to something. I'm trying to move forward through something. I'm trying to move forward as successfully as possible, get things out of the way and make my brain resilient. And I'm going to do that not just by some aids that might help this. And I'm not arguing that there isn't a possibility for pharma to help. I'm not saying that. I'm just saying it's not enough. It's just not enough. And we're going to have to, as a society, recognize that you have to be honest with people. The idea that you have a compound that's going to solve all this because you're so good at replicating what the brain does with a single pill that does one thing is just never going to happen. And that message is just plain wrong. The hope is in that there is something you can do, and that's an investment for you and your health. And somewhat of I think, a relief that, hey, I can do this. I have access to this. This is me. This is my ownership. This is my community. These are the things that are meaningful to me now, has meaning. And not just meaning, but have value for how you are going to do in the future. That message is just not out there loud enough. And there's certainly not something that the pharma companies even get at all. And I would argue most PD researchers just don't get at all. If all we're thinking about gene therapy, then there's something clearly missing. And that is understanding how the brain works.
So eloquently put. You've spoken an awful lot there in immense detail. We can only touch the surface of this fascinating subject. If people want to find out more about this and about your work and Parkinson's, where can they go?
Well, I do have papers out. I like to point to a website, but it's still a work in progress. But certainly looking at my name, Petzinger, Giselle Petzinger at USC. I also have a couple other podcasts out. Rhonda Patrick and I did a podcast. Also someone in yoga did a podcast. So I've done a couple podcasts, but basically kind of covering this at different levels. So, yeah.
No, it's a fascinating subject, and it's a pleasure to listen to you talk so passionately about it. Dr. Giselle Petzinger, thank you so much for your time today.
Thank you. I really enjoyed it. Thank you so much.
If you enjoyed that video, I know you'll get some value from this video right here.